I are going to talk about neonatal respiratory distress. For those of you who might not know, this is Angie Bruton. She is an RN over in OB, and she's also our NRP instructor. So that's the neonatal resuscitation program. So she teaches everybody in the hospital on that. So the first thing that we wanted to just point out is that we have a policy now, and if you look at the papers in front of you, one of those is that it's only 2 pages, it's a pretty quick read. It is the Neonatal Respiratory Distress and Supplemental Oxygen Protocol for here in our hospital. Now, we did base this off of a talk. A gentleman from Indianapolis, from the Women's Hospital, came in from the NICU there and talked about this rule of 2 hours that you may have heard of before. So any of you that might have gone to that talk or watched it, I think Tasha has that online as well, so you can review that too. But so the reason that we made this was to make sure that everybody knows how to administer oxygen safely. We know now that oxygen can cause some damage. It's not just a benign kind of thing that you can use, whenever you want. It's something that should be used like any kind of medicine, anything that we do here. Something that should take some thought. So then the next thing I put on there was the definition of respiratory distress in a neonate. So when a newborn, it's similar in babies or kids, and even some of these things show up in adults, but there are a lot of different things that might be considered respiratory distress. If they're breathing fast, so respiratory rate greater than 60 times a minute is too fast for a newborn. Now that may happen for the first few minutes during the transitional period, when a baby's just born, but it shouldn't persist beyond that. So that's something to watch for. Any kind of retractions, flaring of the nose, that means that they're working harder to breathe. A grunting sound, every time they breathe for them to make a sound, that's not normal either. Any kind of tugging, which is more like, you can see that they're using the muscles, they're using things to pull the air in. If they're turning blue, cyanosis is always a bad sign in pretty much anybody we see, but certainly in the newborn. And then an oxygen saturation for newborns, we would consider less than 92%. Now this is more like, let's say it's an hour or 2 after the baby was born. Less than 92% is not a good sign, so that would be considered respiratory distress as well. We'll show you in a little bit here what the normal oxygen saturations would be for that transitional period, the first few minutes and things after birth. That's a little bit different. So. And the main thing that the protocol goes over is this rule of 2 hours. This was something developed by some people who did a lot of studies about smaller hospitals. What should we do? We don't have a NICU, so how do we decide, what kind of thinking process do we go through to determine if a newborn needs to go to the NICU somewhere else, like in Indianapolis or St. Elizabeth, those places in Lafayette, or are they safe to stay here? So you can see the infant will be considered for transfer if one of the more of the following is true. A chest x-ray that's done. Now first, initially, the only reason you would initiate this protocol is because they're having respiratory distress, right? So you have a newborn, they've been sitting there, in the nursery for a couple of hours, and suddenly they have this respiratory distress. So they're tachypnic or having retractions, their oxygen is low. So then we would do a chest x-ray. If it's not normal, that would be a reason to consider transfer. If the infant is requiring more than 40% oxygen, so normally we use this oxy hood, and if we have to use more than 40% oxygen, that's a pretty significant amount of oxygen that we're needing, and that means there's something probably more serious going on with the infant, and the baby would probably need to be transferred. And then the infant is worsening. At any time, if the infant is getting worse, despite giving oxygen or doing things to try to help, that's a bad sign, and obviously that neonate needs to go somewhere where they have the NICU available as well. And then this one down here is really the 2-hour rule thing. If 2 hours have passed and the infant is no better, that's another thing, especially in all the studies that they did with all the smaller hospitals. If it's been 2 hours and you've had the baby on oxygen, or you've been doing a whole bunch of different things to try to help this baby, and they haven't turned around that quickly, that 2 hours is a long time for a neonate. Just think how much of a percentage that is of their life, right? They've only been around for 2 hours and 10 minutes or something, so that's almost their entire life that they've been having trouble. They should get better pretty quickly. If they don't, that is a reason to send them over to the NICU so that they have more intensive care. So, all right. And the protocol, if you go through it and look at it, it does mention, I'll point out, it's in bold and everything, that when a newborn is noticed by one of the nurses in OB, or anybody that's over there, that the baby has respiratory distress, respiratory therapy and the physician of the baby will be called. So that kind of starts this whole process here. So that is and you guys can take a look at that. And then I'll let Angie go ahead and talk a little bit about the neonatal resuscitation.
A lot of you are probably aware that in 2010, there was actually a several nation committee that was formulated to look at resuscitation and the use of oxygen in newborns. And with that, what came out of that were some new guidelines for the NRP program. We're going to talk, there's several things, including how you teach people about NRP. But one of the things we want to talk about today is the use of oxygen. Used to, before, whenever we're doing resuscitation, we started immediately with 100% oxygen. New recommendations are to try starting without any oxygen therapy. There was evidently quite a bit of controversy surrounding this. Lots of, let's say, colorful conversation, I believe is how it was described, in regards to this. So, but really most of the studies are showing that when you look at room air at 100 versus 100% oxygen, there was increased survival rate when resuscitation was initiated with just air. Okay, and then there haven't really been studies done that have evaluated between the air and the 100% as to how babies do. But we know that premature infants specifically who are exposed to high amounts of oxygen during early parts of their life can have significant sequelae later in life. So they came up with this guideline for what the oxygen saturation should be for a newborn during the first 10 minutes of life. We have done a lot of studies on what SATs are on babies inside, and we know that the pressure gradient needs, their SATs need to be lower so that the mom's oxygen flows through the placenta to the baby. So babies actually start with a lower oxygen percentage than what they do as they progress into life. So this is the guidelines that they came up with. So if you have a baby born here at our hospital, we do not have air readily available in all areas of the hospital. So they have provided us with blenders so that we can begin to blend that oxygen. The kind of resuscitation, the PPV device that we have, we can give positive pressure ventilation without turning any oxygen on through it and be able to administer 21% oxygen to the babies. So currently, that is what we are recommending, we're teaching, is to just start with your bag and mask without any flow to it at all. And then if your baby is not responding, then you're going to go ahead and turn your oxygen to 100% and then get the SpO2 on and begin to monitor where we are and adjust the oxygen based on how old they are and what the percentage is that's reading on the SpO2. Okay, so that's the big change that's occurred in the NRP in how we are giving care to babies here.
Are these going to be posted?
We actually have them on our warmers. All the warmers have the target preductal SpO2 posted for you to look at. And the more we've been going through these simulations with people, practicing, and the more deliveries that we're beginning to use this with, we're also seeing how important it is to get that APGAR timer turned on. So if you are in a delivery helping us out, and you're not sure what to do, that would be great. Hit the button as soon as that baby comes out to start that APGAR timer, or remind other people, because if you're pushing with a patient, you're distracted, you're maybe holding a leg, you're not able to actually reach the button. But we have found it is extremely useful to be able to see exactly where you are time-wise when you use the APGAR timer that's on the warmer.
Is this happening in the OR too? Right? Does this count for the C-section babies? Because they're, you know, they have a little different
Yes.
timeline with secretions and such. So that still is counting for them.
Yeah.
Okay.
We're using it for all of them.
We need to hit the button on the wall.
On the warmer.
We have it on the warmer.
It's on the warmer.
Oh, good, okay.
Yeah, it's on the warmer that we have down there.
All right.
We are working right now with Greg in trying to get, surgery actually has air, an air supply. But it's, the anesthesia machine is using it. So we need to get a dual hookup so that we will be able to utilize that with our warmers. The newer warmers that we have, which the newer one is in surgery right now, has the blender already built into it. But we need to have a continual, we have a continual oxygen source, but we don't have a continual air source. So we have tank air that we can use, but we only have 20 minutes roughly, something like that, if you're using all air, straight air available. So then you have to change out your tank. So it's not ideal, but for what we have right now, that's, so if we could get, you know, air down there, that would be great. That's what we're working towards. Any other questions? Most people that are coming out of the NRP classes are saying that although they don't enjoy the videotaping portion of it, that they're finding that it actually is very useful in seeing how things went and really helps them to do a better job the next time they go through the scenario, or feel like they have it more concretely in them when they go to help in a delivery.
Yeah, when you're doing the resuscitation and you're right in there, it is hard to tell. You know, you might estimate that it's been 5 or 10 minutes and it's only been 20 seconds, and though things are a lot different. So when you watch it, you might look and go, wow, we just stood around, looking around at each other for a long time, and you can watch the time go by and things. And that's why also pushing that button is helpful, because yeah, you might guess, so I think have we been resuscitating for 20 minutes already, and the baby's only 3 minutes old, and the O2 sat, that's okay for it to be 70%. So that definitely helps, something objective. So okay, we have a case to talk about. We had recently, Angie and I both had a patient. I called her baby girl patient for HIPAA reasons. Anyway, she was born in April, and she was 39 weeks. She was born by repeat C-section. The mom happened to be a G3P2, and this baby came out, and for Angie and I both, she seemed to have more secretions flowing out of her mouth than we had really ever seen in an infant before, the neonate. So she must have gulped in a whole bunch of food as she was being pulled out from the C-section. And when she got over to us, she just kept flowing. And yeah, so we did a whole bunch of suctioning, of course, right away, and her APGARs ended up being 6 and 9. So at 6, obviously that it was a problem. She wasn't making good regular breathing attempts. I would characterized her as being apneic for a certain amount of time. So we went ahead and Angie started the positive pressure ventilation. And again, we have the bag that inflates on its own, and so she was able just to use the bag and mask and do that. And most of the time, babies respond pretty well to that. And this baby did. She started, making her own respiratory efforts pretty much right away after we did that. And then my estimate, after we got upstairs, I was like, did we do that positive pressure ventilation for what, like 30 seconds, 60 seconds? And she was like, no, it had to have been at least 2 or 3 minutes. So
we tried to stop and let her, but she just wasn't staying regular with her respiration. So then we'd step in and help again.
So luckily she did start kind of breathing on her own. Then we did do some oxygen afterwards. We attempted to get our O2 sat, and unfortunately on that warmer downstairs we sometimes have a lot of trouble with the connection, and it didn't come up as anything that looked to us to be realistic to be like what was truly the O2 side of the baby. The baby turned pink and was moving, and at that point, we were feeling the heart